All right, hello everybody, welcome back. We are on to a new unit. This is our anesthesia unit. We're going to start with chapter 13, which is our preoperative medications. This is a super short chapter. Okay, so the first thing that's going to happen is the patients are going to get a preoperative evaluation. This is an anesthesia assessment. It's performed on all surgical patients, and it is performed by the anesthesia care provider. That may be a CRNA, it may be the anesthesiologist, or in some cases, maybe an anesthesiologist assistant. The purpose is to gather patient information and determine optimal anesthesia plan. Basically, they're going to identify the patient, what kind of medications they are on, and allergies. And then upon conclusion, a written anesthesia consent is gone over between the care provider and the patient, and then it's signed by the patient. Once all that necessary information is obtained, the patient is given what's called an ASA score, which classifies the patient's physical status. There is a table on 13.1 on page 179 that breaks down those scores. They're basically a 0, 1, 2, or 3. Okay, so we'll go over some of these preoperative medications. First thing we're going to go over are the sedatives. These are given to relieve anxiety. They may have amnestic effects or antiemetic effects. Most commonly used preoperatively are the benzodiazepines. These are a chemical classification of drugs that are used to control anxiety. In low doses, they provide relief of anxiety. In higher doses, they can produce a sedation and an anterograde amnesia, which means from that point on, the patients don't really remember a whole lot. That is sometimes why you'll hear a lot of patients think that they are actually anesthetized in pre-op, and that is because they are given these and they don't remember anything from that point on. These include diazepam, which is Valium, lorazepam, which is Ativan, and midazolam, which is Versed. That's also the most commonly one that is given pre-op. We're going to move on to the analgesics. Analgesia literally means pain relief without pain. When indicated, opioids may be administered preoperatively. An opioid refers to all drugs that have a morphine-like effect. Okay, morphine is the generic name for Astromorph and is a natural opioid. However, the most common synthetic opioid to be given pre-op is meperidine, otherwise known as Demerol. Okay, the anticholinergics. These are agents that block the parasympathetic nerve impulses. They exert systemic effects. They're not commonly used preoperatively, but they may be indicated in specific instances to inhibit mucus secretions of the respiratory and digestive tracts. And remember, that is because we don't want any kind of aspiration. It's most frequently used pre-op are atropine, scopolamine, and glycopyrrolate. May be used intraoperatively to block the vagal response to certain stimuli, such as when we're stretching the peritoneum, or we are manipulating the bowel, or we're doing some cervical traction in the GYN cases. Okay, the gastric agents. This is actually the last category of this chapter. I told you, super short. Patients are NPO usually for an amount of time before surgery. It's usually 12 hours. And this is to empty the stomach of any contents so that we can avoid aspiration. As we know, if they were to aspirate during induction or while they're tubed, they can inhale that. It can go into their lungs and cause a pneumonia. So the gastric agents also aid in the prevention of that. There are two insights, 13.1 and 13.2 on page 180 and 181 that I would like you guys to read. Those give a good review on gastric physiology, and it also gives a short little bit of reasoning as to why we'd like their patients to be NPO. Okay, so the first thing we're going to go over are antacids. These are used to chemically neutralize gastric acid already present in the stomach. Sodium citrate with citric acid, also known as Bisitra, is a non-particulate liquid antacid that is used pre-op. Histamine receptor antagonists are named for their physiological action on the receptors found on the parietal cells in the stomach. So in blocking the H2 receptors, H2 refers to histamine receptors, they interfere with the production of gastric acid. They're available in oral form for over-the-counter use, and you'll probably recognize some of these names. But the most common given pre-op are famotidine, which is Pepcid, and ranitidine, which is Zantac. To be the most effective at intubation, it is best that these are administered 2 to 3 hours prior to surgery, which works out because we usually have our patients show up about 2 hours prior to their scheduled surgery time. Okay, proton pump inhibitors, or PPIs, bind irreversibly with the acid pump or parietal cells and prevent the release of gastric acid. They're most commonly prescribed for oral administration in the medical setting to treat GERD. PPIs are examples of prodrugs. The prototype drug is omeprazole, also known as Prilosec, but it is not used pre-op as it takes a few days for it to be fully effective. So those that we use pre-op are Prevacid IV, Nexium IV, and Protonix IV. These come in freeze-dried powder form, so they need to be reconstituted before they are administered. And they usually relieve the gastric acid in about 20 minutes. All right, antiemetics are used to reduce nausea and vomiting and to minimize the post-operative nausea and vomiting. That's that PONV. So patients at risk for PONV include pediatrics, especially pre-adolescents, patients who have had or will receive opioids, barbiturates or etomidate. And the female patients, also types of surgery can have an effect on the nausea and vomiting. If we're working around in the stomach and the abdominal cavity for an extended amount of time, obviously there may be some PONV involved with that. The 3 main categories, of medication used to prevent PONV are gastrokinetics, neuroleptics, and serotonin antagonists. All right, so metoclopramide, otherwise known as Reglan, is a gastrokinetic used to reduce gastric fluid volume, usually used in pregnant, diabetic, difficult airway, and emergency patients. These are patients that may not have time, especially our emergency patients, may not be NPO. And what these do is they stimulate the upper GI motility without gastric secretion. So it's going to stimulate the stomach to empty, but it's not going to stimulate the stomach to make any kind of acid or secretions. Okay, then we have droperidol, which is enapsin. This is also an antiemetic with sedative properties. So it is not frequently used. It's really only used as a second line of defense. Okay, then we have ondansetron, which is Zofran. This is the most commonly used antiemetic, especially in surgery. It's given IV over about 2 to 5 minutes immediately before induction. And lastly, we have scopolamine. This is a dermal patch. It's applied the night before or immediately before surgery. It's usually applied right behind the patient's earlobe, and it's left in place for about 72 hours, and it really does a good job of treating that PONV. Okay, like I said, guys, that is the end of this chapter. It's super short. Any questions, please leave them, and I will see you in just a little bit.